Hi, I'm Dr. Mike McInnes. Welcome to the video answers for the Part 1 question set number 1. You should have already downloaded the PDF and worked through the questions on your own. Don't skip that step. It's a really important part of the learning process. So, if you've already done that, let's get going. First question, which immune response is responsible for hyperacute, acute, and chronic transplant rejection? And what's the time frame for each? Now, I'm actually going to start with the time frame and then I'll give you the immune mechanism. So hyperacute rejection begins almost immediately, within minutes of the transplant being placed in the body. So what kind of immune response is capable of attacking a transplanted organ so quickly? Preformed antibodies that are already circulating in the host's blood. So this is a type 2 hypersensitivity reaction. Acute transplant rejection takes weeks to develop. This is more of a cell-mediated immunity, where cytotoxic T cells recognize the foreign major histocompatibility complex molecules, the MHC molecules, and then they attack. So this is what immunosuppressant drugs are trying to prevent. And then chronic transplant rejection takes months to years to develop. And this is where those cytotoxic T cells now begin to think that the foreign MHCs are actually self-MHCs that are presenting non-self antigens, and they start to attack. And this is more of an insidious, irreversible process. Next question. What's the treatment for digoxin toxicity? So first of all, you're going to normalize serum potassium and magnesium levels, which is fairly standard treatment for all types of arrhythmias. You can give anti-digoxin antibody fragments if the toxicity is severe and if it meets specific criteria, which fortunately you don't need to know for step 1. But these antibody fragments are very rarely given because they're extremely expensive. And if the patient's bradycardic, you can give atropine. And if there's some other type of arrhythmia, such as ventricular tachycardia, then you're going to follow the ACLS protocol for that specific arrhythmia. Next question. For which infections is vancomycin a good choice? So the main use for vancomycin would be to treat multi-drug resistant organisms like MRSA or enterococci. Then you can also use oral vancomycin as a second-line treatment for C. diff colitis. Now usually vancomycin is given IV because it's not absorbed orally. But if you have a patient who's not responding to metronidazole, which is the first-line treatment for C. diff colitis, you can go to oral vancomycin because you don't want the vancomycin to be absorbed. You want it to kill the C. diff that's in the gut. And then, how does vancomycin resistance develop? Well, normally vancomycin works by binding to a cell wall precursor protein, and it inhibits cell wall synthesis. The binding site on the protein is 2 alanine residues in a row, and they're dextroalanine, so it's D-alanine, D-alanine. Now, bacterial resistance occurs by changing this D-alanine sequence to D-alanine D-lactate. When this change is made, the vancomycin can't bind to that protein, so the bacteria is now vancomycin resistant. Next, do atypical antipsychotics primarily address the negative or positive symptoms of schizophrenia? So first of all, what's the difference between positive and negative symptoms of schizophrenia? I like to think about positive symptoms being abnormal things that are being added, so it's positive. Things like delusions, hallucinations, disorganized speech, disorganized behavior. And then negative symptoms are where you're subtracting normal things from the patient's personality. So the patient might have social withdrawal, so you've subtracted their normal social interaction. They might have lack of motivation, where you've subtracted normal motivation. They could have flat affect, where the normal expression of affect is subtracted. Or they could have lack of speech or lack of thought. Now, atypical antipsychotics primarily address the positive symptoms of schizophrenia. In general, it's easier to treat the positive symptoms of schizophrenia than the negative symptoms. I want you to remember that. I like to think about it being easier to get rid of something that's not supposed to be there in the first place, like delusions or hallucinations, than it is to bring back something that's been lost. So it's easier to get rid of positive symptoms that you've added than it is to bring back all the normal stuff that you subtracted to get the negative symptoms. Now, that being said, the atypical antipsychotics do tend to work better on negative symptoms than the traditional neuroleptics like haloperidol do. No doubt about it. But again, regardless of what you're treating with, atypical or a typical traditional neuroleptic, if you have a schizophrenic patient with 2 positive symptoms and 2 negative symptoms, it's going to be easier to get rid of those 2 positive symptoms than to restore the 2 negative symptoms. Students seem to get tripped up on that all the time. Then the second part of the question is, how does the mechanism of action of typical antipsychotics, which are also called traditional neuroleptics, how does that mechanism of action differ from the mechanism of action of the atypical antipsychotics? So the typicals block the D2 dopamine receptors, and then the mechanism of action of the atypicals isn't really fully understood. They act on a lot of different receptors: dopamine receptors, serotonin receptors, H1 histamine receptors, and also alpha adrenergic receptors. All right, next question. A 67-year-old man with new onset hepatic failure and normal renal function is currently taking a drug metabolized and excreted by the kidneys. Would you need to change the loading dose or the maintenance dose of this medication because of this hepatic failure? Now, there are 4 important pharmacokinetic equations you need to know for your Step 1 exam. I'm not going to go through all of them right now, but we're going to cover them in Part 2 of the course. But 2 of those important equations deal with the loading dose and the maintenance dose. Loading dose is the amount of drug that you give when you're starting the drug to get the plasma levels up to the therapeutic range. Then the maintenance dose is the amount of drug you have to give to maintain that plasma level over time. Now, loading dose is determined by the target plasma level, the concentration at steady state, and by the volume and distribution of the drug, and also by the bioavailability. So hepatic failure doesn't change any of those things. So the loading dose isn't going to change. But the maintenance dose is determined again by the concentration at steady state and bioavailability, and also by the clearance of the drug. So any disorder that affects drug clearance is going to affect the maintenance dose. But this question says that this drug is renally cleared and this patient's renal function is normal. So in this specific case, the loading dose doesn't change either. So in this instance, neither the maintenance dose nor the loading dose needs to be changed. Now, if this patient were to develop hepatorenal failure, would you need to change the loading dose or the maintenance dose? Again, renal failure isn't going to affect the loading dose, but if this drug is renally cleared, then the maintenance dose is going to need to be reduced. Because again, the maintenance dose is partially determined by the clearance of the drug. Next, what substances compose the matrix of the bone? So 30% of the bone matrix is an organic matrix of collagen and chondroitin sulfate and hyaluronic acid. And then 70% is crystalline salts of calcium and phosphate. The primary salt is hydroxyapatite. And then lots of other things are conjugated to those hydroxyapatite crystals, things like magnesium, sodium, potassium, carbonate. Other elements that can also conjugate to the hydroxyapatite crystals include strontium, uranium, plutonium, lead, gold, other heavy metals. It's not really known what role these other conjugated elements may have in the function of bone. Next, while thiazide and loop diuretics are known for wasting potassium in the urine, there are other diuretics that conserve potassium. So which diuretics are these? Well, these are called the potassium-sparing diuretics. So instead of allowing the body to lose potassium in the urine, these diuretics help to block the excretion of potassium so that it sticks around. And the mnemonic we have for this is potassium, take a seat, because you want that potassium to stay put. Take a seat. And SEAT, S-E-A-T, stands for spironolactone, eplerenone, amiloride, and triamterene. And the next part of the question asks, what are their mechanisms of action and what are the important side effects? So spironolactone and eplerenone are both aldosterone receptor antagonists. They block aldosterone receptors in the principal cells of the collecting tubule in the kidney. And aldosterone is supposed to make the kidneys reabsorb sodium and water. When you reabsorb sodium in the collecting tubules, you're excreting potassium. Now, amiloride and triamterene act on the same part of the collecting tubule by blocking the sodium channels, but they don't antagonize aldosterone. They work a little bit differently. But in either case, if you block that action with one of these potassium-sparing diuretics, potassium is going to stay in the body and not be dumped into the urine. Then for the side effects, all of them are keeping potassium in the body, so there's a risk of hyperkalemia. And you should also know that spironolactone is an antagonist at androgen receptors, so that can cause some gynecomastia in men. And it also has some progesterone agonist activity, and that can cause some menstrual irregularities in women. Next question. A 66-year-old woman is being treated in the ER for acute MI. Nitroglycerin is given with the expectation that it will vasodilate which vessels preferentially. Now, this is an important point to know not only for your test, but also in the wards as well. This is a classic PIMP question. Because students always want to say, well, it's dilating the coronary arteries. But the correct answer is that nitroglycerin relieves angina by dilating peripheral veins. So think about it. In a patient with angina or an acute MI, the coronary vessels are already going to be maximally dilated. So the main effect of nitroglycerin is to dilate peripheral veins. Now, why is that going to help relieve angina? Well, when those veins are dilated, what happens to preload? Preload decreases, which means that the heart doesn't have to work as hard. When the heart doesn't have to work as hard, it doesn't need as much oxygen. So by giving nitroglycerin, you're indirectly lowering myocardial oxygen demand. Then the next part of the question says, another patient in the ICU is on hydralazine for acute treatment of his severe hypertension. Now, how does hydralazine function? Well, hydralazine is an arterial vasodilator. It works by increasing cyclic AMP in vascular smooth muscle cells, which leads to smooth muscle relaxation. So you can think of nitrates as venous vasodilators, and hydralazine is an arterial vasodilator. And occasionally we might give both of these drugs together so you can have both of these effects simultaneously. Next, what risk factors are associated with cholesterol gallstones? So the mnemonic for this is the 4 F's. Fat, fertile females over 40. So fat is obesity, which increases the risk of gallstones. Fertile reminds you about pregnancy, because pregnancy increases the risk of gallstones. The more you've been pregnant, the higher your risk. Women have a higher risk than men. And then age over 40. We hardly ever see symptomatic gallstones before age 40. And then what risk factors are associated with pigment gallstones? So pigmented gallstones are seen in patients with chronic hemolysis, alcoholic cirrhosis, advanced age, and biliary infection. And the last question, a 35-year-old woman with multiple sclerosis presents to the clinic with internuclear ophthalmoplegia. So what is internuclear ophthalmoplegia? Internuclear ophthalmoplegia is also sometimes called the MLF syndrome because it's caused by a lesion of the medial longitudinal fasciculus, or MLF. So MLF syndrome means that when you have the patient look away from the lesion, the ipsilateral medial rectus muscle is weak or paralyzed. And at the same time, there's nystagmus in the contralateral eye, the abducting eye. So again, this occurs when they attempt to look away from the lesion, so you'll sometimes see that called attempted lateral gaze. But when you test convergence by having them follow your finger across their eyes, with convergence the medial rectal muscle works just fine. Now, internuclear ophthalmoplegia is a classic sign of multiple sclerosis, but in older patients you'd also need to consider stroke as a cause. All right, that's it for this set of Part 1 questions. I'll see you next time.